Mohamed what?
Yeah, Mohamed Bouattour.
Mohamed Bouattour. So it's my pleasure to introduce you here in Egypt, and I know quite well your experience in the field of HCC, and we are waiting to hear a lot about the future concepts and updates in this field. Professor, start your talk, please. Thank you.
Thank you very much. I would like first to thank the organizer committee for this kind of invitation, Ahmed Raib for this great welcome, and everybody for this very nice meeting. Unfortunately, I see there is little bit less people with more interesting topic, which liver. But anyway, I think we will hope we will have discussion together and to see together what we move in strategy for primary liver cancer. This is my disclosure. My plan was to look for a critical role for screening in primary liver cancer, advanced in hepatocellular carcinoma care, and future direction and collaborative care. To be honest, my topic will be focused only on hepatocellular carcinoma, but if you want, we can discuss after that for cholangiocarcinoma, but I prefer to focus only on hepatocellular carcinoma because it's more frequent, as you know, and I think there is a lot of direction more in hepatocellular carcinoma. So, you know, and I think it's true worldwide, that hepatocellular carcinoma is a global public health care and issue. This is true because at least this is some issue we can observe. There is we know there is a high incidence rates worldwide. There is a significant mortality rate. The diagnosis of hepatocellular carcinoma was often occurs at advanced stage. There is a limited adherence to screening programs, and of course there is inherent poor prognosis related to complication arising from both cancer and the underlying liver disease, which is cirrhosis. And this is complicate our mission. This is some example of issue we can observe, and we know that also over the time the landscape of epidemiology shifts from viral hepatitis toward alcoholic liver disease and metabolic associated liver disease, the MAFLD, the new MAFLD. And this was, as you can see here in the figure, for example, the age standardized incidence rates per 100,000 persons in 2019 is high in Egypt as well as in France. It's around for 100,000 persons in 2019, and the variation during the 10 years after between 1919 and 2019 is quite increasing, even as I said, in Egypt and France. However, you can see, for example, in China is decreasing because the management of hepatitis B and management of patients with viral infection. And in the second part of the slide, you can see that the distribution of hepatocellular carcinoma etiology transit from, as I said, viral to non-viral etiology between the last decade. And this was also seen here. It is true for Western population. You know, it's the viral because it remains the principal cause and primary cause of HCC in Asia and most African region. On the other hand, we know that the overall survival and the overall prognosis of hepatocellular carcinoma remains poor, even in Western countries. Here, this is two examples of two large cohort, one, the Italian one, with 600 patients, even that it's old cohort, but we know that when we take all patients with hepatocellular carcinoma, the median overall survival, regardless of the treatment, regardless of stage, is 9 months. Similar results was observed in a large cohort in database of French administrative database. More than 13,000 patients with hepatocellular carcinoma were studied in this database, and we know that there is difference in management depending on the region, and access to the treatment. And when we look for the median overall survival for all this population, it's also 9 months. We are 10 years after. And only 20-30% of patients will eligible or candidate to curative treatment. Even in our hospital, we have looked for our database. It's an old database, but anyway, between 2006 to 2008, 300 patients were recorded, and we know that 36% of them were in median criteria, so eligible to curative option. 64 of them were out of median, and when we look for survival, it remains low, 17.3 months. So, before discussing any therapeutic innovation in liver cancer, I think it's important to focus on simple, effective measure with screening of high-risk population. This is the improvement of prognosis of hepatocellular carcinoma is not possible without an appropriate screening program at high-risk population. This is what will be happening in Japan, as you can see here. This is a study with 5,000 patients included in the study. Japanese one, when they adhere the screening program, 80% of them were detected through a screening program. The majority of them were in median criteria and eligible to curative treatment. In the opposite, in Hong Kong, the majority of them do not adhere the screening program, and so the majority of them were not eligible to curative treatment, so the prognosis was clearly lower. So we must screen high populations, raise awareness among the population and all physicians about the importance of screening. And this will be done by a very simple tool. You know, this is an very old study, French one, a controlled randomized trial which performs screening occurring ultrasound with alpha-fetoprotein, but anyway, ultrasound 3 months versus 6 months. Finally, we know that when you perform ultrasound every 6 months, we are able to identify or to detect a patient with ACC and with lesion, which of them it will be ACC, and to manage them earlier. So it's simple. Ultrasound every 6 months. This is the important message, I think, for this topic. This is the old data, but there is some teams are trying, and here probably the radiologists were more aware than physicians. They are trying to detect, to use other tools, innovative approach to detect ACC in earlier stage. This is an example of an American one, the 3 centers. This study was a retrospective cross-sectional study. They use it, what they call it, the abbreviated MRI. So it's not complete MRI, just 10 minutes. This takes 10 minutes. Enhanced T1, T2 weighted, and diffusion sequences. And they look for 352 patients with cirrhosis resected, transplanted or resected. From them, 138 were without ACC, and 161 with ACC. And the gold standard was, of course, the resection specimen. So the resection specimen will be the standard of the gold standard. What the author observed that the sensitivity and specificity of abbreviated MRI is high, 88% around. It's good exam to detect early hepatocellular carcinoma, early lesion, especially hepatocellular carcinoma. Yes, sensitivity seems to be lower for child PUG patient and child C, but probably the most important was child PUG A, because this is a patient who we should screen them. And I think this is an interesting study. This is a study by our radiologist, Maxime Renaud, Professor Renaud, and my colleague from Avicenne, a pathologist. They ask if abbreviated MRI, so it will be fast MRI, in 10 minutes, it is able to identify or to detect nodules and ACC for patients with high risk of hepatocellular carcinoma. So This is a sample phase 3 trial, which is currently occurring in France. Around 1,000 patients will be included. Patients with high risk of developing hepatocellular carcinoma, so with calculating of risk higher than 3%. They were randomized to be screened by ultrasound, as usual, or ultrasound plus the fast MRI. And after that, I hope we will answer on the question, is any place for this innovative approach for detection of early stage ACC? This is what we observe as an advancement in management of patients with hepatocellular carcinoma currently. You are probably aware, for those who work on liver, on this classification of the Barcelona, the BCLC classification, that will classify the patient according to tumor burden, liver stature, and so BCLC-A, so it will be earlier stage, BCLC-B intermediate stage, BCLC-C advanced stage, and accordingly they will propose an algorithm of treatment depending on, as I said, on the advance of the ACC. So this is the concept was so old, but currently in 2024 there is an advancement and there is change of the shift and paradigm of this treatment. Of this algorithm. We can see, for example, when we call the transition treatment stage migrations, it means that patient in early stage initially could move to earlier stage after different treatment, and I will show you after that some examples of this migration. The integration of some local regional therapy, including radioembolization, and of course systemic therapy that we will discuss it. This is just to show you what changed in this highlighted in yellow here or in orange, what changed on this algorithm, especially, as I said, the migration, the local regional therapy, and of course systemic therapy in 2004 compared to 2012. So I'm so sorry for our surgeon. I take from another one, Dr. Sepulveda, these slides, and I thank him. But of course, Professor Safidogma is here. He can, after, of course, give his insight about. But I think when you measure advancement, at least the advancement on surgery was the robotic perspective. I don't know if you have ever seen this robot. It's an impressive machine, but I think our surgeon, they use them to operate with these patients. The advances, it will be augmented 3D vision, more precise, 3D construction imaging device software. I think here the tumor, infrared camera. We can move it, of course, and of course it could increase risicability. Not for our patients, but it could be the future perspective of robotic in this population. And so the question, another question in surgery is, should we perform laparotomy or laparoscopy for hepatocellular carcinoma? This is a small study of American one, I think. 56 patients were treated in each group. 56 in hepatic resection robo-assisted, laparoscopy, open hepatic resection. What we can observe, this is a retrospective one, that laparoscopy and robo-assisted surgery have patient resected by laparoscopy or robo-assisted surgery had longer duration, operative duration, significant shorter length of stay, no significant difference in other perioperative parameters and incidence of postoperative complication among the three groups, no difference in terms of disease and free survival. So this is, I think, the interesting data. I think Professor Dokmak will confirm it. And for this, we will try to answer this question prospectively, and this by another study, which Beaujon was the principal coordinator and the sponsor of the APHP, and we will look for the interest of laparoscopic approach compared to laparotomy approach. So the patients were randomized by either to be resected by laparoscopy or by laparotomy, and the objective was we estimate that there is superiority of laparoscopic approach compared to open approach in reduction post-operative morbidity in patients with hepatocellular carcinoma. I think the study is currently finished and we will have data soon. Another approach was to downstage patients or to perform neoadjuvant therapy. This is, I take some examples because we have a lot of approaches, but I think the radioembolization as an approach to achieve resecability. So this is a French study also. 216 patients with a big tumor, higher than 5 centimeters. They have been matched between resection and radioembolization. From patients treated with radioembolization, you can see that 27% of them were resected. What we observed with this study, after propensity score matching, patient resected after radioembolization had better overall survival at 1, 3, 5 years based on this operated upfront. You can see the numbers here, and it is different. And compared to patients resected upfront, pathological analysis showed significant higher tumor necrosis in patients treated with TARE surgery. And this is what you observed. I think I would like to thank Aurélie for these cases, which a patient resected after radioembolization, initially not resected, downstaging after radioembolization. We can see that Valérie, she is here, she can confirm, initially poorly modulated hepatocellular carcinoma with necrotic fibrosis. This is the macrovascular invasion, tumor vascular invasion. After radioembolization and the patient resection, we can see that the presence of high level of anti-tumor lymphocyte, PD-L1 expression was increased after we have biopsy before and biopsy after. The PD-L1 expression was increased after surgery, after radioembolization, So we can support, if any, rationale to add immunotherapy for this patient or in these approaches. The other innovation was a very recent study, the Emerald-1 study, which is a phase 3 trial looking for TACE, transarterial chemoembolization associated to immunotherapy, here the durvalumab plus bevacizumab compared to placebo. I will give you this scope of this year because it's just published or communicated at ASCO GI this year. We can see that patient treated with durvalumab plus bevacizumab plus radioembolization, chemoembolization, have better PFS, 15 months compared to 8 months for patients treated only with TACE only. So the trial was positive. We don't have results of overall survival, but this is a signal of the association and improvement of PFS with a patient treated with chemoembolization added to immunotherapy and anti-VEGF. The other advancement was, I think, the measure one, the systemic therapy for advanced hepatocellular carcinoma. You know, there is for over 10 years, I don't know exactly what we will use in Egypt, but for 10 years, only TKI were approved for patients with advanced hepatocellular carcinoma since 2007. For many years, there is no improvement, at least no new drugs until lenvatinib. But currently, from 2020, we have the arrival of immunotherapy combined to anti-VEGF or double immunotherapy with atezolizumab and bevacizumab and durvalumab plus tremelimumab. I will discuss just after that the results. Here the concept of combining immunotherapy with anti-VEGF and the synergetic effect. We can see this was confirmed by the EMBRAVE trial. Atezolizumab plus bevacizumab do better than sorafenib. You can see here the median overall survival was not reached in the primary analysis for atezo and beva. Updated results show that median overall survival was 19 months compared to 13 months for patients treated with sorafenib. You can see hazard ratio at 0.66. Which never reached for patients with advanced hepatocellular carcinoma before. So very impressive results. The objective response rate was 30% according to RECIST and complete response 8%. I want to show you that you pay attention that the relatively quick separation of the two curves it is possible that there is a rapid effect of an anti-VEGF. So this is what we can observe according to this curve. On the other hand, the Himalaya trial was this one compared an anti-CTLA-4 plus anti-PD-L1, shown similar results in terms of overall survival and improvement of overall survival. You can see the hazard ratio was 0.67, and which is more interesting, I think, it's more the Q of the trial of the curve. You can see that we observe at least 25 or 30% of patients with high long survival rate, as you can see here, more than 36 months, so 3 years after the initiation of treatment. So probably it needs weeks. The combination of lomethimazole immunotherapy, it needs weeks to build anti-tumor effect. And for this, I think here there is the separation between the two curves was later, as I said. So this is probably an effect of durable effect of immunotherapy in the time, and not like atezo plus beva, which is more quick. How to make a choice between the two combinations? We don't have data, of course. We don't have any argue to choose one by another. Just we consider, of course, patient selection choices of doctors, biomarkers of response. We don't have it now. Cost effectiveness, and probably we suggest, because of the difference between the two curves, using atezo-beva, but it's just suggestion. Atezo-beva for aggressive tumors and bulky tumors, and to consider combining immunotherapy for less aggressive tumors. And this is the currently the schema of systemic therapy into currently. Atezo-beva was standard of care in first line. If not possible for contraindication, so durva-treme and so TKI were used in second line. We should take into account that there is no trial using TKI in second line that prove their efficacy after atezo-beva, because they was compared, but so the majority of us use TKI as second line when immunotherapy failed. And just to give you the new data, of course, of systemic therapy as an adjuvant setting, this time, these patients were resected or ablated. They were randomized to receive atezo plus beva, or to have an active surveillance, randomization 1 by 1. Risk factor, the trial was stratified according to the ablation or resection and the risk and duration. And the primary objective of the study was the RFS, the recurrence-free survival. Just to mention that the authors and the trial defined patient with high risk, so big tumor, macrovascular invasion, VP1, VP2, number of tumor higher than 3, but anyway, so the high risk of patient with high risk of recurrence. And you can see here the trial was just published in Lancet, and you can see that the 12 months recurrence-free survival was 79% for patients treated with atezolizumab compared to 68%. This was considered with, of course, side effect of immunotherapy. This was considered as positive, and this atezolizumab was approved, for example, by the FDA. In France, or at least for the MA, it's not exactly the same because it's a little bit challenging. We don't probably the combination. We don't have enough follow-up to confirm this result. The median recurrence-free survival has not been reached in the two groups. The curves were converged around 18 months after the randomization. We don't have, as I said, the final overall survival analysis, and it is possible that we don't know if there any benefit for a Western population because the trial was especially included patients with hepatitis B, so Asian 1, 82% of them, and 62% of them was hepatitis B. It's true we rejected more patients with hepatitis B, but we don't have only this population. So I almost finished. We learned a lot of. We have a lot of work, I think, ahead of us. This is some suggestion of what direction we will take, or we will hope to take. Explore the integrative of modern devices, advanced technique, and artificial intelligence to enhance early detection of ACC. Investigate innovative approaches to refine screening strategy and improve diagnostic accuracy. Investigate the potential benefit of robotic surgery focusing on anatomic resection, ensuring, of course, free margin, preserving hepatic parenchyma. Assess the impact of robotic-assisted procedures and on surgical and oncological outcomes. Just give you some direction for the future systemic therapy. I'm sorry. First, I hide the slide, but there is a question in the first session about is any place for intrahepatic therapy, at least for hepatocellular carcinoma. So there is some tentative of intra-arterial administration of immunotherapy for CD1 inhibitor, for vaccine. So the combination of different systemic therapy, including anti-PD-L1, anti-TIGIT. So there is a lot of future direction we are looking for, and I hope we will have some new results in the future. So this is my conclusion. I think there is a critical role for screening of patients with high risk for enhancing patient survival. We cannot improve this patient survival without a good program screening and to adhere to the program screening. It is important to integrate all this in a multidisciplinary team discussion with radiologists, with pathologists, with the surgeon, with oncologists, with the pathologist and others. And this multidisciplinary decision is important for individualized treatment decision and strategies. And thank you very much for your attention.